Welcome back, focused learners. Today we're diving into part 25 of our CPC exam series explainer. We're decoding the evaluation and management coding principles for office and outpatient settings, which is honestly one of the most heavily tested areas on your entire exam. Before we jump into this massive EM shift, make sure to like, share, and subscribe to Decode Healthcare with Harshal.
Okay, let's look at the syllabus for today. We've got 1. The modern E&M framework. 2. New versus established patients. 3. The 3 MDM elements. 4. Scoring MDM with the rule of 2. 5. Time-based code selection. And 6. An EM summary and cheat sheet. Grab your notes, let's get into it.
Section 1. The modern EM framework.
So under the old guidelines, coders had to rigidly count history and exam bullets, right? It often felt like this frustrating math exercise. But under the 2021 and 2023 framework, there's a fundamental shift. While history and exams are absolutely still clinically required and medically appropriate, your code selection is now based exclusively on either medical decision-making or total time on the date of the encounter. Don't waste precious time on your exam counting bullets if the question is set in this modern framework.
Section 2. New versus established patients.
And this brings us to the famous 3-year rule. A new patient is someone who has not received any professional services from a physician of the exact same specialty and subspecialty in the same group practice within the past 3 years. Listen closely to this part, because here's a classic CPC exam trap. If a patient sees a partner in the same group practice who has the exact same specialty at, say, year 2, well, they are established. Always double-check the specialty and the group before you code.
This single rule essentially splits our office codes into 2 completely distinct families. New patients fall into the 99202 through 99205 range, while established patients land in the 99211 through 99215 range. A really quick exam tip to help you memorize this: the new patient codes have a 0 in the middle, like 99202. Think of that 0 as representing 0 prior visits in the last 3 years.
Section 3. The 3 MDM elements. Medical decision-making, or MDM, is driven by 3 main pillars. You've got the number and complexity of problems addressed, the amount or complexity of data reviewed and analyzed, and the risk of complications or patient morbidity. Let's break each one down.
Element 1 focuses purely on the problems addressed during the encounter. These are categorized into 4 levels: minimal, low, moderate, and high. So a minimal problem might be a self-limited minor bug. A moderate problem could be an exacerbation of a chronic illness, and a high problem involves a severe, high-threat-to-life condition. The absolute critical rule to remember here is that the problem must be actively managed during that specific encounter. Simply mentioning a past resolved condition in their history, that doesn't count towards the complexity.
Element 2 is all about the cognitive work of handling data. This isn't just skimming a chart. It involves tests ordered, independently reviewing external records, analyzing lab results, maybe gathering history from an independent historian, or even having a direct discussion about management with an external physician. Also, independent interpretation of imaging falls squarely into this category too.
Element 3 evaluates risk. Again, we're looking at minimal, low, moderate, or high levels. A fantastic benchmark to just lock into your memory for the exam is that prescription drug management automatically places the encounter under moderate risk. On the flip side, if a provider makes a decision regarding hospitalization or opts for elective major surgery in a patient with significant systemic risk factors, that encounter gets bumped all the way up to high risk.
Section 4. Scoring MDM. Rule of 2.
So to qualify for a specific MDM level, whether that's straightforward, low, moderate, or high, you must meet or exceed the requirements in at least 2 out of the 3 elements we just discussed. We call this the rule of 2. You absolutely do not need all 3 elements to be high to bill a high code, just 2 will do the trick.
Now, here's a highly effective, insider, practical strategy for exam takers. Score your problems, score your data, and score your risk. Then, just visually strike out or drop the lowest of the 3 elements on your scratch paper. The remaining 2 elements will confidently and accurately dictate your final MDM score every single time. It's a real game changer.
Section 5. Time-based code selection. For most EM codes, you can select the level based on whichever pathway is more advantageous for you, time or MDM. If the provider clearly documents their total time, and it actually equates to a higher code level than their medical decision-making supports, use it. It's perfectly allowed and highly beneficial.
The crucial point here, though, is knowing what actually counts toward total time. This includes face-to-face patient time, plus non-face-to-face activities like chart review, documenting, ordering tests, and care coordination. But wait, there is a massive caveat here. This must be the total time spent by the physician or qualified healthcare professional, often called a QHP, strictly on the date of the encounter. Clinical staff time, like your medical assistant taking vitals or rooming the patient, is strictly excluded.
If that physician or QHP's total time exceeds the maximum threshold of the absolute highest level code in that specific category, you can introduce prolonged service codes. Remember this distinction for different payers on the exam. You're going to use 99417 for standard CPT guidelines, but use G21212 if it's a Medicare patient. Just be super careful to only apply these when the absolute maximum time limit is entirely surpassed.
Section 6. EM Summary and Cheat Sheet.
I highly recommend taking a screenshot of this visual cheat sheet right now so you can use it during your exam prep. I'll give you a second to grab it. Okay, remember, MDM, or total time, drives the code. The 3-year rule determines new versus established. The rule of 2 dictates your MDM level, and total time includes both face-to-face and non-face-to-face physician or QHP work on that exact same day.
Mastered these office rules? Good, because in our next explainer, Part 26, we are tackling hospital inpatient and observation E&M, consultations, and emergency department rules. And spoiler alert, ED coding is strictly MDM only. Keep studying, stay focused, and I'll catch you in the next one.